folks, welcome to Creating New Healthcare. So excited, so interested in the work that our guest is doing today. I think she's going to open up a window to a side of healthcare that, quite honestly, most people in healthcare are really unaware of, and that is employer-based healthcare. And she has spent a good part of her career in that domain of healthcare, and so we're gonna hear right from the source here. Dr. Marla McLaughlin, why don't you tell us a little bit about your career, and I'm rearing to go with questions.
Sure, absolutely. Thanks for having me. So I am a family medicine physician by training. The first 3 years of my career, I spent in a very traditional fee-for-service, kind of turn them and burn them, eat what you kill, primary care that was owned by a hospital system.
Mm-hmm.
I learned a lot. I did a lot of high volume, but I just thought, I don't think this is how healthcare should be delivered, right? All the financial incentives are based on volume. Nobody was ever asking about the quality of the outcomes of my patients, which is what I was passionate about. So for the next 12 years of my career, I was in an on-site employer-based healthcare system. It was very unique at the time. Aging myself, that was back in 2008. It was advanced primary care. We had a pharmacy on site. We had behavioral health. We had health coaching. And we were doing full scope primary care for all the employees and their families. And, advanced primary care is so much about population health. That employer-based healthcare is population health. And so it's something I'm very passionate about, both the model of advanced primary care and the way employers are investing and delivering it for their employees, I think could be a real game changer. And making all of this on a value-based financial system where really, to be successful, you have to show outcome and quality care, which also very passionate about.
So can I call you Marla? Marla,
Yes,
is that okay?
Of course.
So, I think you said a couple of things which I really, really respect and resonate with, but I want to clarify. The first is advanced primary care. That word gets thrown around. What does advanced primary care mean to you?
Thank you for asking that, because I was just in a meeting last week kind of saying, let me tell you my brand of advanced primary care. And I hate to say that, but if you Google it, you'll get 10 definitions.
Mm-hmm.
The way we look at it is it is a multidisciplinary care team, meaning, we come at this from several angles: primary care, behavioral health, health coaching, pharmacy benefit, like letting everyone work to the top of their license to really just wrap around this patient and make it very patient-centered. I think another real key is that it is data-driven. And whereas for many years, let's be honest, the good doctors were the ones that people liked, and that's fine. I mean, that's important too. But it is an industry that really probably lagged in having to prove effectiveness. And that has all changed now. We have data sets. Now, I always say that data and those quality metrics and all those things that we chase, those should be the outcome of a really highly functioning advanced primary care model. They shouldn't drive the model, right? And so another aspect of advanced primary care is just being highly coordinated. The concept of primary care kind of being the quarterback. And, I'm sure we'll kind of get into this, but, we have to morph with the times. And I always say, it doesn't matter who I'm talking to. If I'm talking to one of my physicians in my clinics, what I'm saying is, I want to make for you the right thing for you to do, whether that be hit this checklist, all the things I need him to do. I want the right thing to do, to be the easy thing to do in the EMR. Same thing for patients. I want the right clinical next step to be the easiest next step in the path of least resistance.
Yeah.
So I think what advanced primary care, so that's what advanced primary care means to us. And I would rely heavily on the data piece.
Yes.
And I think it also is really wrapping your services and matching the level of your resources towards the risk of the patient. I think that's another super important piece. High-risk patients get all of the airtime, and it's super important. I don't deny that that's necessary. However, we also have a lot of hidden risk, apparently healthy, and people that can even truly be in a well category, and they don't need to be wrapped with all those resources. We've got to meet these people where they are.
When you talk about advanced primary care, tell me if I'm hearing you correctly. And I'll be totally transparent. This is a hypothesis or thesis I've been talking about and thinking about and hoping to write about. Primary care cannot just be the old time primary care. You see the doctor in the office and you go out. What you're adding to it is a bunch of things. One of which is this comprehensive look, like you said, behavioral health, pharmacy, health coaching, et cetera. The other thing you're adding to, which I think is really important, is a population health approach. So it's not just primary care. I don't have a name for it. If you have a name for it, maybe it is advanced primary care, but it's the secret core. And this is when you look at the other countries around the world that are doing amazing health, having amazing health outcomes. They don't do primary care alone. They marry primary care with a population health approach. Those
Absolutely.
two work together.
Mhm.
And you're saying we have to know, am I as a clinician, am I as a healthcare provider, as a system, et cetera, am I actually for the people I am serving as a whole, am I lowering their blood pressure? Am I helping them with the diabetes? Am I actually giving them the preventive cancer treatment? Am I helping them with their weight? Those metrics have to be at that population health basis. I mean, that's the way you measure it. And so I'm just kind of curious if you agree with that or how you see that primary care slash population health. And to your point, it's like identify the high risk. But what I heard you say, and I love that, is there are people who look healthy today and
Mhm.
who are low cost. So you go to the claims, but you know what? Within 12 to 18 months, they're going to have that MI, that heart attack, that stroke, something's going to happen. We have to identify the people who are at potential risk
Yes.
and do something proactively. So I said a lot, but I'm curious how this all, and please correct me or change, if you have a different way of thinking about it.
No, I actually think about it exactly like you do. It's kind of interesting because if you do these advanced primary care models well, you actually increase cost initially for a short period of time. Why? Because if you're doing it well, you're going and uncovering those apparently healthy. And that takes a minute to uncover them. I'm not saying it's super expensive, but it takes a minute. Whether you start with biometrics, whether you're increasing the colon
Great
cancer screening,
point.
all of the things. And so you have to first and foremost set out real expectations, right?
Mm,
You're going to increase costs temporarily. You're going to uncover the apparently healthy, and then in the long term, you're going to save those costs. Where it gets interesting with employers is that, and I understand why, it's such an absurd year over year increase that they're saying to us, hey, we believe in what you're saying and we want to get on board for the long game, but also what can you do for us this year? And I get it because they're
mm,
spending so much money. And if you think about it, going back to what you said about primary care before, so, back in the day, I think primary care got kind of a bad rap. And I'm talking about back in the day, 80s, 90s, the HMO, you're the gatekeeper. And it was kind
mm,
of just got this negative connotation.
mm-hmm.
Whereas we all know now, fast forward, primary care, everybody knows this can be the answer. Why can it be the answer? Because primary care is the great navigator. You can have
Mm-hmm.
all these fancy tech things and these apps, and I'm not against those. I think they're great, and I'm sure
Right.
we'll get into that. But the
Yeah.
point of primary care is the great navigator. Now, before that was in a negative light, you're the gatekeeper. No, it's the great
Mm,
navigator. And so when you look at how the system used to be, it was that the specialties operated in silos, and we were the quarterback for the care. And we really were the only ones always seeing every piece of the puzzle. Now, what's happened is employers have started investing in point solutions. I'm not against point solutions. It's an
yeah.
interesting way to enter the ecosystem. However, again, if you don't have somebody kind of quarterbacking all your point solutions, all you have is silos. And I always say, I have not met a human body that works in silos. It's just not how it works. And
Right.
if these aren't talking to each other, and I always give this example where I had a patient, and this isn't a terribly long story, but it's just kind of the point. He came to
Mm,
me for an annual physical. He felt great, apparently
mm-hmm.
healthy, right? And I saw that his hemoglobin, which people on maybe watching this aren't medical, it's just your blood count. It was drifting down. It had drifted down significantly a full gram in the year before. And I thought, that's a little much. And so you always think, okay, is he losing it in his GI tract? You
Right.
go down the typical things.
Colon
Primary
cancer, right? You're thinking
colon
colon
cancer.
cancer. Yeah.
Yes. That's the first thing we got to rule out. Well, primary care can do 80% of these workups. And so I go down that path. And really long story short, there was a question. We couldn't find anything GI wise. Is it a bone marrow issue? And for that, you
Uh,
need to refer to hematology.
right.
In that same thing, we had uncovered that he had very, very low testosterone, secondary
Mm,
to sleep apnea. So he's also seeing someone for his testosterone. My point in saying this is what happened was testosterone side effects, raise your blood count. So I'm watching this happen where they're treating him with testosterone. She's repeating over here a blood count and saying, oh, I think it's resolved.
oh, wow.
There was nobody wrong. in this situation
Wow.
that I was like, oh, you think it's resolved because of a side effect he's having from this med. My point
Mm.
is, that's in the old fashioned days. And what did I do? I picked up the phone. Hey, did you realize, this and that?
Hmm.
We've got to morph that to today's age because really these
Mm.
point solutions have developed that same dynamic, but there is not a primary care point solution.
That's right.
So I think it's like talking to
Well,
employers about you've made all these investments. Let's make them work
yes.
together.
You know, I talk about this a lot. There's point solution fatigue, which I've been through as on the other side as an employer, representing an employer, and you get all these vendors coming to you with their I've got the diabetes thing, I've got the diabetes app, I've got the cholesterol app, I've got the hypertension app,
Yeah.
I've got the sleep app, I've got the wellness
Yeah.
depression app, and the poor employer, and forget about the employee. How does an employee actually even recognize all of this?
Right.
And so I agree with you. I think primary care, I love what you said. I wrote it down. Primary care is the great navigator. I think primary care is the great platform.
Mhm.
And, we've forgotten this. It's like, it's interesting because we're all used to apps and all that sort of stuff, and including wellness apps, and everyone's wearing wearable devices, but I think of the real value, and as a primary care physician like yourself, I think the real value is someone helping you to make sense of it all and to manage it
Tell the
all,
story. Yes.
right? And to your point, I really think primary care is not just a navigator; it is your platform. It is your. I think of so I used to think of myself as a primary care physician, almost like a contractor.
Mhm.
Like very few people can go out into the market and hire electricians and plumbers and architects and this. You hire, cement, blah blah blah. You hire a contractor because there's so many different things, and the
Yes.
contractor has been through this 1,000 times. They also know who to talk to, who not to talk to, what to beware of, what you should be worried about, what you should not be worried about. Now you have to trust the contractor,
Yes.
but I really thought, primary care is like the medical healthcare contractor. And we're losing that. And I don't think people understand
Mhm.
how you can't, it's hard to explain that to someone. People only understand that after something bad happens to them or their family member.
Yes.
But
Yes.
as a primary care physician, you see that every single day, like you prevented something bad from happening. If that person hadn't had you as a primary care physician, God knows what would have happened. It's so hard to prove that out, but I really think that's the value of primary care.
Well,
One of the values.
I completely agree. And I think, it's one of the things where you and I have a feeling have the exact same perspective where, I had a panel of 2,500 people. I could have told you in a hot second anything about them. I could have told you who their family members were. I could have a teenager come to me with an issue and I knew what was going on between mom and dad because I took care of the whole family. Now
Wow.
we have to be realistic that time has morphed. And
Mhm.
so I'm one of those like, I'm not going to beat my head against the wall fighting against it. I'm going to be part of
Right.
the team that tries to make sure it's done well. Right. And I get it. Like people have a phone in their hand. We have to do apps. These ecosystem partners could be great. There's a lot of great tools out there, but if all they result in is globs of data that nobody's interpreting, it's not helpful.
Mm.
And so I look at that stuff as, hey, there's a lot of objective things in medicine. And there are a lot of things that can follow an algorithm. Now, would I love to put
Yes.
a personal touch on that? Yes, but I'm not going to battle that if I feel like it's objective. What I hope those things do
Mm.
is really preserve the face-to-face patient time for the art of medicine
Mm.
because that's what's being lost. And that is the
Mm.
storytelling.
Mhm.
And that is the taking all the pieces and putting it together in a way that is digestible for a patient. I mean, the fact that we think, patients, I always say patients always know what they want, and that's fine. That's human nature. They don't
Mhm.
always know what they need. And so, how can we, even with these tech solutions, be injecting, here is your next best step clinically? If you type in, I need help with knee pain, no, you do not need to see an orthopedic surgeon.
Mhm.
So, how do we develop these solutions where people are getting clinically relevant, accurate information? And
Mm.
I think that's why, where I work, we have two companies essentially running alongside each other. One's advanced primary care and one is tech and data.
Mhm.
So it's like the merging of these two worlds, and we both benefited from each other because the tech and data is not good if it's not clinically informed.
Mhm.
And the clinical stuff has to continue to move forward and has to be in line with the least, uh, you know, uh, you know, how people can proceed and make their next
Yeah.
decision with the
Mhm.
least friction. And that is
That's
going
a
to be technology. It's going to be
that's
technology.
so so costs are definitely the biggest pain point. And I really love what you said before that if you bring good primary care in, which would be, top priority for any employer or consultant working on behalf of an employer, you might see initially an increase in cost because you're going to have more discovery.
Mhm.
Um, and, but I would imagine, well, let me ask you, in your experience, does that potential bump in costs, will you see that reverse in the second, third years as you reduce, the low risk people who then become high risk?
Mhm.
Is that what you're seeing?
If you look at a runway, we usually start seeing significant savings around year three.
Year three. Okay.
Uh-huh. And so it's not a huge long game because you can imagine. I mean, the reality
Yeah.
is employees are also moving around more than they used to, which is
Yes. Yeah.
why the benefits have to be, they
Yeah.
really want to have a benefit package that attracts people.
Yeah.
And they want to have conversations where 20 years down the line, we all know GLP-1s, I mean, they're revolutionary. Now, can we put a date on when you're actually going to save money? I can promise you, you will. But
Yeah.
it's hard, right? And will they still be their employees then? And I don't
Right.
think it's them trying to be difficult. I think they're trying to be realistic about their costs.
Right. Right.
And so, I feel like there's good investment going on in the employer space. There's frustration about the lack
Mm.
of utilization of the things that are in place.
Oh, I just, you said that before. You used the words engagement.
Yes.
So I just want to explain to people who, again, aren't very familiar with this world. So you pay money for a product, could be a point solution like a diabetes solution or even primary care. Typically, you're paying a PMPM, a per member per month for
Hmm.
all your employees. So
Yep.
essentially, you bought something for every employee and you're paying a certain amount every month. It's just like, you buy an app, except it's not just for you, it's for everyone.
Right.
So the problem is, again, this is background information. I'm curious as to your thoughts about it. The problem is that if only 5% of people are using it, you're paying for the other 95% who don't use it.
Hmm.
And so in the end, what's the return on that investment?
Right.
So do employers, are they concerned about the engagement and what
Yes.
have they done? What are you doing?
Yes, we've done all kinds of things. And yes, I would say overall, yes, very concerned because here's their investment. And if they genuinely believe, and they do, or they wouldn't have invested, that this is going to improve outcomes, well, they don't want to improve outcomes for 30% of the people.
Right.
And so we've done all sorts of things. So, for instance,
Yeah.
biometrics is a hot topic. Biometrics came about because you're trying to uncover hidden risk, and it's the big ones, right? It's
And wait,
hypertension.
and could you explain, Marla, just what does biometrics mean?
Absolutely. So biometrics in general is when a company says, usually incentivizes, not always, but usually incentivizes and say, hey, as part of your plan, we're going to have you go through this process of screening. And it's usually a finger prick that screens for diabetes. It screens for elevated cholesterol. And then they also do check a blood pressure at the same time. So screening for hypertension. And then they usually do a neck and waist circumference and a weight and height, right? So they're screening for obesity. So if you think about those things, all of
Mhm.
those hidden risk and silent things minus, people usually know if they're overweight. But it really is, I mean, as far as who set that up and what they're screening for, perfect. Then employers start going, okay, we'll do that. We'll invest in that. And now we're going to incentivize people to go do it. Great. Also,
Right.
really good step. So, like, we have an employer who has a 90% engagement with the biometrics. Why is that? Well, because they put incentive behind it so people come. So I said to them at one point, okay, you now have 10 years of
Mm,
biometric data. Has
mm,
anyone ever done anything with it? And the answer was, well, not really. I'm like, okay, well, let us see it. And so what we decided, looking specifically at that population, is we were going to do two things the next year. I said, first of all, let me put a health coach there. Anybody who is out of a
mm,
perfectly normal blood pressure range, I want them to walk over to her and talk to her
mm,
right then. And we're going to make this real easy for them. They don't have to
mhm,
come see us for a visit. We can get them a home monitor. That health coach can follow up with them.
mhm,
And so we embedded ourselves in their already
mhm,
made process to make sure something happened with it. We had
mhm,
significant results in the people we engaged with versus the people that we did not.
mhm,
Um, the next thing we did was we said anyone who has an A1C of 6.5 or higher who has never had a diabetes code dropped on them in the data,
mhm,
we're going to outreach to them proactively and get them in for primary care. So what I find for engagement
mhm,
tactics, what works best? Well, the people that are going to come, right? And you're going to get about 25 to 30% just by being there, just by being convenient, all those things. And then the other ones, you have to get permission from the employer to reach out to the unengaged.
That's brilliant. That's what
Mhm.
you and your numbers are right. When I look at the vendors out there who do primary care, they typically tout about 25% engagement. And you're right, you make yourself available, convenient, but to get to the rest, you're going to have to do something more. And so you're basically saying, we go out, we grab the data. This is that population health part we were talking about before. You go
Mhm.
out and you say, can I have some data so I
Yes.
can see in your employee population who has abnormal labs? And then you reach out to them and say, hey, listen, we can help. You've got something that's abnormal here. We can help you out, whether it's a high hemoglobin A1C indicating that you have either pre-diabetes or diabetes. You have a high blood pressure on, that was recorded that you haven't been following up on. What else are you using so you, now where do you get that data, by the way? How does an employer give you, like, they don't have the electronic medical record because they're not a healthcare system. So how do you get that
No.
data?
They send, we have a data warehouse. And so if I start talking technicalities, you'll laugh at me. But the employers send it to us some way, shape, or form through the air. I'm kidding. But yeah, through files, that go into our data warehouse. Now, it is true that some employers prefer we work directly with the payer, and we're fine doing that. We can do it
Mhm.
either way. Some employers have a third party in place that works with both the payer and the employer, and sometimes we go through that third party, but we can aggregate the data ourselves. So I think that's one thing when I talked about advanced primary care that kind of makes us unique. We pull data from our EMR. We get all the claims data either from the payer or the employer. We pull that in, we put them all together, and then we have a better overall view of the patient because on our tech piece in our app, we have 240, we call them genius segments. And that's like, here, you could, like, for instance, you could end up in
Mhm.
three segments. You could be a male that needs a colonoscopy. You could be a male that looks like you have metabolic disorder that could progress to type 2 diabetes. You could be a male that's at high risk for back surgery because of some PT claims and MRI claims and such. And so it puts you in these different categories, and then we can personalize the outreach.
So you actually get, through the claims data, you can actually get clinical information that can guide you and who would benefit from,
Yes.
a primary care visit. And you said the EMR. So where do you, I mean, what EMR, since it's an employer?
Oh, okay. So when we go, like when we are on as Vera Whole Health, like for instance, we use the Athena EMR. So we go
Okay,
set up these clinics, and these are all our ecosystem. And to your point,
got
like
it.
there's of course a lot of laws and this and that. So the employers don't have access directly. We report out unidentified data to the
Got it. Okay.
employers. Yes,
So you get it through
through our own EMR.
your own clinics that have your electronic medical record system. You mentioned before, your approach, which is kind of high touch and high tech with these two companies, Castlight and Vera, that now are part of Apri, I believe. So pre-health. What's your kind of take on AI, the use of these advanced technologies? Where are you seeing it help right now, and where you see it in the next 2, 3 years,
Yeah,
5 years?
it's a hot topic, and I think a really fun one. I mean, it's just I think insane how fast that's advanced. So, right now we are seeing that it's very quick uptake as far as using AI to do like we do a lot of benefits transparency, right?
Mhm.
Things that are very objective that are on our app, like what reward do you get? What is your deductible? All the things that are being run by AI that work very well. Employers love
Mhm.
that piece.
Mhm.
We personally are using
Mhm.
AI like in our EMR. So I don't know about you, but I hated being triangulated with a laptop. But the reality of my life was that I've got to be looking at this typing, or else I'm going to be at home tonight during my family time doing all this work. So I've got to be looking at this computer while I'm talking to this patient. Well, now, I mean, you don't have to be. Just have that laptop on. You have your good conversation face to face, make a meaningful connection, and you got AI in the background creating the note. It has been a complete great game changer for our providers.
Mhm.
Now, fast forward that out to AI for patients. That's where it gets a little
Mhm.
more debatable. And by debatable, I don't think anyone disagrees that there's a role for it. I think
Mhm.
people's tolerance for where that boundary sits, as far as what kind of decisions can be made through just algorithms, that's where we're going to have to continue to work. And I've heard it from all different directions. Super liberal on how far the AI can go. You kind of see this, it's physician backed. Well, what does that mean? What does that mean,
Mhm.
physician backed? And at what point does the physician get involved?
Right.
And then you've seen the ones where it's very basic. If this
Mhm.
is a basic conjunctivitis, and it sounds like it's likely viral, and you go literally down this algorithm. I think it would be honestly probably a waste of all of our time to really battle against the things that are super objective.
Mm-hmm.
Because in a perfect world, that frees up the physicians that are still here because we have such a shortage in primary care
Hmm.
to be doing things that aren't super objective, which in my heart are the more important things.
The literature shows us that primary care visits, just primary care visits alone, does not actually change health. And so I've had people, I actually have a colleague who was challenged in a conference, and it's just like someone raised their hand and said, primary care is BS. The research doesn't show any change. Well, if you actually dive into it, here's the thing. We know that the things that primary care does improve health outcomes, right? Controlling blood pressure, controlling diabetes, diagnosing cancer before it's end stage. So we already know that, okay? So we know there's value in primary care and preventive care. The thing where I think the fallacy in the research that's been done to date on primary care is the primary care visit in and of itself is not going to change anything. What's important, and you said this, which was why I'm coming back to it. It's what you do after the primary care visit. Do you actually follow up? So, you say you need these things, but are they done? Are you actually working on the weight? Are you working on the blood pressure? 50% of Americans, 50% have high blood pressure. 80% of those people, that's 4 out of every 10 Americans, it's not controlled.
Oh
It's
yeah.
not controlled. I
Yep.
mean, ludicrous. I mean, this is bread and butter. I mean, the medications are cheap, cheap, cheap. We know
Yep.
what to do. It's all protocolized, and yet 80% of hypertension is uncontrolled. And so, this is basic stuff. It is, and by the way, as you know, it's the number one cause. If you want to say what's the one thing we could do to save lives in America, I
Mhm.
mean, 600,000 to 800,000 deaths a year. So let's just focus on that. But the point is, to your point, I think it's like we got to do the primary care and we have to have the follow up. And I
Yeah.
do wonder if there's a way, instead of all this AI being, like I don't need to know my resting heart rate or my heart rate variability. I need the advanced technology to help me make lifestyle changes. And I
Exactly.
wonder if AI is going to help us do that in the future. I would love for it to help that.
Yeah, I would too. And I think, for instance, in our technology, we call them nudges, but the nudges are
Yes.
not the same. Like your app would not look like my app because it's
Right.
picking, even if I say I typed in therapist, if it
Mhm.
knows I'm high risk, it's going to send me right to one of our behavioral health therapists or our providers. If it knows
Mhm.
that I'm low risk, it may
Yes.
send me to an ecosystem partner, right? Like a
Yeah.
behavioral health
Yeah.
ecosystem partner. Like it shouldn't even
Yeah.
do the same thing based on your
Yeah.
risk aggregation in the background. So
Yeah.
I do think there is a world in which some of the things that right now we say, let's not fix that with a human, because it's rather objective. I do think
Right.
there's some of that stuff that AI is going to be incredibly helpful with.
Hmm.
I mean, I think the debate that's going to go on, and it's going to be ongoing, I think, for a while, is where do you insert the human risk benefit art of medicine? At
Hmm.
what point do you insert that? And can we all, we're not all going to agree, let's be honest, but can we
Yeah.
agree and can we get employers to be comfortable with that?
Yeah. Dr. Marla McLaughlin. I've never met you before, but this is the most fun conversation I've had in a while. I respect the work you do and that you're going to be doing. Would love to follow up with you. And this has been a great conversation for me about not just primary care, but also the larger challenges that employers and employees face in their own healthcare. So can't thank you enough.
Yeah, it's been a lot of fun. I really appreciate it.